Recording. Here we go. Good morning, ladies and gentlemen. My name is Dr. Nicholas Dogris, and you are attending a new webinar in which we are going to cover some really exciting stuff. Cross-frequency coupling. It's a well-established piece of science in neuroscience, and it is something that is now part of NeuroField, and I'm extraordinarily excited about this. You're all muted right now for the purposes of keeping the sound down. During the webinar, I'll do my best to try to bring people up to ask questions and whatnot. Hopefully you all can hear me. If you can't, message me through the chat, and we'll go from there. I made an attempt to make a PowerPoint, and I got into a bunch of slides, and eventually I stopped because I just ran out of time. So I'm going to be going between this PowerPoint and some of the data that I have, and then I'm going to also be going through the actual NeuroField program. Now, I want to just stop us all for a moment and acknowledge that 2 weeks ago we lost a member of the NeuroField community who was a very good friend of mine. And even saying this out loud is hard for me, but I want to observe a moment of silence for Dr. Hank Mann. Hank would be really excited about this. And he was excited about anything we did, but I know he'd be really excited about this, and he was an inspiration to me and a very good friend, and he will be dearly missed. And he'd probably be mad at me for taking too much time on this webinar and say, why don't you just get to it? So with the spirit of Hank, let's move forward. Okay. Now. All right, so cross-frequency coupling. Let's jump into it. Let's see if I can make my PowerPoint move. Here we go. So you're probably wondering what this is all about. If you've downloaded the new 8.06 version of NeuroField, in the actual program, you're going to see 17 new protocols in the NeuroField database. I'm assuming that you guys are here because you've seen those and you're wondering what the heck they are and how they work. And it's going to be my pleasure to introduce this to you. But let's go back a little bit and talk about some of the things that led to this new innovation in NeuroField. Last December, I had the pleasure of meeting Dirk de Ritter in the Cancun Z-Score conference that we had. Myself, Jay Gunkelman, Dirk de Ritter, and Phil Jones, we all had the pleasure of speaking. Oh, and Mike Gismondi, too. We had a great time there. And while I was watching Dirk speak, he gave a really, really great presentation. And there was a number of things that I really appreciated about it. But he talked about the way that the brain communicates. And he talked about networks. And he talked about the Rich Club, which is, there's a bunch of Rich Clubs in the brain, but these are neuronal hubs that communicate with each other. And he talked about how they communicate. And my learning style is to, I'll listen to information to a certain degree, and it kind of gets in there. And throughout the day, I was listening to his discussion. And that evening, we went out to have dinner. And as we're walking down the street, it just hit me. I knew that that talk that day was going to get me. And Jay Gunkelman and Dirk were talking about nesting frequencies and how the anterior cingulate can speak to the posterior cingulate and what needs to happen in order for that to occur. And Dirk said something to the extent of, well, that's great, but, you know, how would we do that? And I said, I think we can do this. And so when I came back from Cancun, began looking into this Rich Club. And as you can see here from this this little screenshot, there's a good article that I'm going to throw into the next release of NeuroField. It's called The Rich Club, and there's it talks about what they're calling the human connectome. And this is where they take an enormous amount of MRI data and they start to figure out what regions in the brain are well connected and the most connected. And if you look at this, you can see that the superior frontal lobes here and the precuneus and the superior parietal are really, by the thickness of these connections, are some of the most dominant hubs in the brain. And when Dirk and Jay were talking about it, it was interesting because they were saying, well, what has to occur in order to make these hubs talk to each other is to have a combination of slow frequency delta or theta and gamma. And the idea would be that, you know, gamma is such a high frequency waveform that it has difficulty being able to traverse the path between these hubs. But if gamma is riding upon, if gamma is riding upon either delta or theta, then you can traverse the path between the network hubs. And I thought, well, what an interesting idea. Okay, so let's keep looking at that. So there's research that indeed shows that slow frequency theta and delta will carry gamma. And that depending on the studies that you look at, in this particular study, there was a memory task given to a person. And every thing that the person was required to remember would elicit another gamma spindle that would ride upon a theta carrier wave. So the science is actually established that this does indeed occur. There is cross-frequency coupling and nesting of gamma and theta, gamma and delta, and probably gamma and anything below delta. So naturally, you start looking into some cross-frequency phase lock, phase shift data to see if indeed does this actually occur. Is there a change in the phase lock and phase shift metrics that you can actually observe through the QEEG? And I don't know about you guys, but for me, I've been looking for something in, you know, some method to change phase shift dynamics. It's one of the most difficult things to see change in the data. And for a couple of years now, I've been searching for something that would do that. And I believe we found it. Now it's a matter of refining it and understanding it. But if you run a LORETA phase shift analysis, a lot of the data shows 3 standard deviations below the norm or 2 standard deviations. It's always low, and it makes me question that. But it's always been consistent in that way. Well, in the analysis that I'm going to show you in a little bit here, not only did we find changes in phase shift and phase lock LORETA metrics, but we found them to be extraordinarily, the magnitude of these shifts are amazing. So in looking in this a little bit further, Bob Thatcher on his website has a cross-frequency coupling video, and I borrowed this slide from his video in which he's talking about what frequencies do what and to what system. And this is really a good one to know, because if you start making your own cross-frequency coupling protocols, which is entirely possible in NeuroField, you can start affecting systems in the way that you want to. All right, so now in looking at the data and reading the studies that I was interested in, said, okay, what rich clubs do we really want to know about? What rich clubs do we want to put the coils over and influence with this cross-frequency coupling? In other words, what network hubs do we want to influence? And this little shot here gives you probably the most important modules for you to take in consideration, with the default mode network probably being the most important one. It also has the highest amount of connectivity and cellular bundles than any other network. So default mode network is definitely one to take in consideration. Now remember, if we use these new cross-frequency coupling protocols, we're going to think about placing coils right over these highly populated nodes and attempting to get them to have communication with each other. Now you're going to ask yourself why. Why is it so important to get these hubs to communicate? I believe that if the hubs can communicate, that it enables the brain to regulate itself in a way that is exponentially more powerful than any other method that we have to date. When the hubs are not speaking to each other or having good communication, what happens is that the amplitudes are at different levels. The asymmetry is at different levels. So the frontal lobe may have an amplitude asymmetry that's much higher than the parietal lobe. And if we were all network hubs and we wanted to regulate ourselves, let's say we did an exercise where we all want to speak at the same volume. Now, in order for that to happen, we all have to hear each other. And if we can't hear each other, then we have to guess at what volume that we're speaking at and what volume you're speaking at. But if we can hear each other, then we can make a pretty good estimation about how much volume we need to have in our voice. And when we all can actually speak at the same volume, then what happens is you get a regulation between all of the hubs. And it's one of the things that I'm noticing in the data. I'm hearing clicking. Let me see if I can mute again. There we go. I don't know if that actually does it or not, but clickety click. All right, here we go. Oh, I lost my screen. Okay, so with this idea, okay, we're going to take these protocols and we're going to try to use a slow frequency carrier to get the anterior cingulate to speak to the posterior cingulate. This is the initial idea and the initial study that I just completed. We have 10 EEGs that we did this and basically the method was very simple. Put a QEEG cap on a person, get eyes open, eyes closed EEG acquisition. Then leaving the cap on the head, we put the NeuroField coils over FZ and PZ. Now the coils are stacked upon each other. So channels 1 and 2 are literally stacked upon each other and then put at FZ. Channels 3 and 4 are stacked upon each other and put at PZ. Then what we do is we load up the delta gamma alpha gamma cross-frequency coupling protocol and give it for 20 minutes. As soon as it's over, we take the coils off the head, we ensure that we have a good EEG connection, and then we take another acquisition of the EEG and we do an analysis looking at the pre versus post EEG. Now this is to simply show that the phenomena that we're talking about, this cross-frequency coupling, is occurring. Now I'm going to warn you, the data doesn't look pretty sometimes, because what's happening here is it's pulling the brain from one extreme to another. And what happens is that there's a stabilization period that occurs after these protocols are given. But I felt compelled to do this study simply because what we're seeing here in my clinic warrants further research. People responded very, very quickly to this method. So, if indeed this is going to work or change anything in the EEG, we should be able to observe some changes in LORETA coherence, LORETA phase shift, and LORETA phase lock metrics. I wanted to look at subcortical metrics and get a sense of whether NeuroField had the ability to make these kinds of changes, which I think are profound. Okay, so here's the first one. Here's a subject, 54-year-old female, and on the left is her pre, and on the right is her post. And this is really interesting. I mean, this is 20 minutes of the delta gamma, alpha gamma protocol. And if you look at the map on the left, obviously we see a lot of high beta here, and we can see beta coming all the way up through the right frontal lobe. We also see a relative deficiency in alpha and in theta and in delta. Now, when we look down here and check out what happened post-test, you can see that the expression of high beta changed remarkably inside of a 20-minute stimulation. It changed the expression of absolute power in alpha. And if you can see here, it's slightly elevated in the back of the head, and then it definitely normalizes. Delta also changed. This is eyes closed. Every one of these that we did, we took eyes open and eyes closed, but this is eyes closed data. What you can see here in the back of the head is that we exposed a hypocoherence. Now, I thought, okay, well, this is interesting because when you look at phase reset metrics, really phase reset is what you would use to calculate coherence. So let's keep looking here. So here is the absolute power pre-post for LORETA. And on the left here, you can see there's definitely a lot of alpha 2 and beta 1 here. But what you see on this right side here is an elevation in high beta. And I believe this is what the cross-frequency coupling changed, because you can see how it regulated quite a bit on both hemispheres, but it definitely regulated quite a bit in high beta, which is what we saw on the surface data as well. But the theory is that if we get that anterior cingulate and posterior cingulate to talk to each other, then they're going to speak at that same volume. And I think what we're seeing here is them speaking at the same volume. It's more of a balancing and a regulation. Now, I'm sure that if we did a number of sessions on this person, we could help to regulate that high beta. Now, here we see what really got me excited. This is Z-score LORETA coherence, and what we're looking at is pre versus post. Pre is on the left, post is on the right. And on the left here, you can see this is Brodmann area 9, which is frontal lobe, and you can see this hypocoherence here in alpha. And it's definitely present, but you don't see all of this hypercoherence here. And you can see how the brain swung an enormous amount in terms of coherence when it received 20 minutes. And this is the anterior cingulate getting activated. And I think what we're seeing here is a compensatory mechanism. If we keep looking through the data, again, now we see it through Brodmann area 10, the same kind of phenomena. And there's massive changes in LORETA coherence across virtually every Brodmann area. Okay, and here is the anterior cingulate, area 24. And again, you can see how there's a massive change in alpha 2 and beta 1. And the entire expression of the brain changes. Now, we keep on looking. Here's area 29. Area 29 is the posterior cingulate. And so now we're looking in the back of the head, and we're looking at how it's communicating with virtually every other Brodmann area. And again, we're seeing a massive shift. Now, one may look at this data and say, oh my God, this is an extreme shift. And I would say, yes, it's extreme, but it's what you see immediately after treatment. What we're seeing here is the brain in transition. So it is definitely one swing. If you think of a pendulum swinging, it's definitely the pendulum swinging to one extreme versus the other. And my prediction here is that you do get a stabilization. There is a midpoint that the brain will settle on. But this is a way to definitely get the brain to change the expression of the EEG. Okay, and here it is again. This data is very significant. These are significant changes. Here's 31. And again, you're seeing massive changes. And here in 31, you can see how the hypocoherence is lessening. And my guess is that, again, this is a compensatory effect that's going to help the brain to be able to speak from one region to the other. As a result, we should see some pretty significant clinical changes. Now here we see phase lock durations. Now we're back to area 10. And again, for those of you that play with the LORETA phase lock and phase shift modules in NeuroGuide, it's pretty rare to see something shift or lock to this extreme. And lo and behold, this is the frontal lobe. You can see area 10. You can see how we have this massive shift in locking in beta 1. And again, this is the anterior cingulate at area 24, where we make the same observations. And posterior cingulate, area 29, we make the same observations. You have beta 1 and alpha 2 changing rather significantly. Now we're looking at area 30, again, posterior cingulate, and it's going through the entire brain. And the entire system is now recalibrating itself. Now here's some really exciting data. Not that the other stuff isn't exciting, I'm excited about that, but I'm extraordinarily excited about seeing phase shift in LORETA change, which is something that is extraordinarily difficult to pull off. And it's something that I've been looking for quite some time. And this data strongly suggests that we can influence phase shift metrics with NeuroField. And the significance of this is that phase shift is highly correlated with IQ. So if you can get longer phase shifts, you get more call-outs to other network hubs in the brain. And in other words, these hubs are able to communicate with each other longer. And it makes sense that we actually see this, because if the phase lock's occurring, then the phase shift is probably also going to change as well. And the phase lock is responding to these longer shifts, which the brain isn't used to doing here. And you can see how at the bottom, if you look on the right hemisphere, you can see how these 3 standard deviation negatives turn into, I mean, we have a 3 standard deviation shift here, which is, again, remarkable to see and rather surprising, actually. So let's look at another one. And here we see it. This is the anterior cingulate, where we see more phase shifts. Again, a normalization with that beta 1. Now, if you remember with the phase lock was, it appeared to be hyperlocked at beta 1. But I think that's what has to occur. The lock has to get longer in order for the shift to get longer, and then there's going to be a regulation between the two. That would be my guess, that this is what's going to occur over time. Here's area 29, posterior cingulate. Again, pretty big changes, demonstrating again that we can get these frontal to posterior nodes to speak with each other. Phase shift duration for area 30. Again, a big shift. And it's difficult to predict the direction of the shift. We know it's going to occur, but we don't know exactly which way it's going to occur. Hopefully it goes towards the mean, which is what we've seen in a lot of people. But I think one of the tricks here with the cross-frequency coupling is to derive protocols that actually are able to, where we can actually predict the shift, where we can say if we give this particular protocol, we're going to shift the brain in this frequency band. And I think that's going to be some of the focus for the future here. Okay, so this is that surface data for the same person. And on the left here, you can see that's the pre. On the right is the post. And you can see how high beta did regulate quite a bit on the surface within a 20-minute period of time. All right, here's another one. I'm a 7-year-old male, and this is the LORETA absolute power. And if you look on the left here, you definitely can see how the brain responds, and there's quite a bit of absolute power increases here in the beta 1, beta 2. Now, if we look on the right here, you can see what happens 20 minutes later. The brain definitely responds to these cross-frequency protocols, and it's going to create a regulation essentially. This is what we see in a lot of cases. All right, so let's jump right into coherence. And again, we see the swing from pre to post. And when one hemisphere regulates, like you see here on Broadband area 9, this is the right frontal. You can see how it's regulating. You can see how you will get a compensatory effect on the left, which is really interesting. But that's what occurs. Here we see LORETA coherence on area 10. And again, this is a massive shift in coherence from pre to post in 20 minutes. And you can see this, area 11 was pretty much offline, and then by the time it's done, 20 minutes later, it's gone from hypo to hyper, which again is the swinging of the pendulum. On the right side here, we have area 24, the anterior cingulate, and you can see the hypocoherence between areas 46 and 44 and how they pretty much regulate within that 20-minute period of time. And here we see the hypercoherences change as well. I know this is an enormous amount of data, but it's all relevant, and it shows the effect quite nicely. And this is something, I'm not going to torture you with all of this data, but this is what I have observed in every one of the people that has gone through this experiment. We see the shift. Okay. Here's area 10. This is phase lock changes, and you can see how phase lock changes in this person quite a bit. And this person has a developmental disorder that's associated with hypoxia. And what you see in hypoxic kids, and I know this well from my own son, is you will see a deficiency in alpha-1. And it's something that I've seen in almost every case that I've worked on with hypoxia or anoxia. And this is really difficult to fix. To get alpha to regulate in these kids has been a challenge. And as you can see here, you see how quickly alpha actually regulates in the lock. It's remarkable that it occurs this quickly. We could spend weeks working with somebody and not move alpha this quickly. Again, you see that change in the shift. This is the posterior cingulate. And getting the posterior alpha to change, again, is remarkable. Okay. Oh, wait, is that all the data I had here? Okay, let me get out of that. All righty. I'll field a couple of questions right now. Okay, so I see some remarks here. Let me go back. Yeah, I know this is okay. So one of the things that I'm going to be doing here, guys, is when I give presentations live, I'll definitely start opening up different kinds of data so we can get a sense of this, and I can do some today. We're seeing changes. I see. Can we see all the frequency bins? Yeah, we'll get to that. By spectrum analysis, I started looking at that, and it kind of shows it. I don't know if it shows it better. These shifts are going through lizard brain, mammalian brain, and primate. It's definitely hitting all layers of the brain because we observe changes all the way down to the hypothalamus and hippocampus and the amygdala. And so that data definitely is there. Let's see. Kathleen says, who do you think we should use this approach with? All comers? Well, that's one we'll get to. Are there still any behavioral coordinates? I don't know what that means. Has Thatcher seen this? Not yet. And I'm going to hit him with this when we go on the cruise this weekend. And have I done more cues? Yes, and we can jump into a couple more. Okay, so let me show you some other cases. This is a lady that we've had coming here since, well, actually she's been coming here since last year. A person with Parkinson's disorder. She gets a lot of relief out of NeuroField, and when you give her Delta, it really does bring down the level of her tremor. But most importantly for this lady, what it really brings down is the rigidity that you see in a lot of people with Parkinson's. Now, when she came in last month, she was looking like this. Let's see here, EO 29 pics. Okay. Can everybody see this map? Somebody type yes. Make sure that you can. I'm pretty sure that. Hopefully you guys can see. Okay, good. There we go. Thank you, Miriam. Okay, a bunch of yeses. Okay, so this is what she looks like when she rolls in here. Now, she looked a lot worse when she started with us. This is current. If I was to go back to, actually, let's go back. Let's go back to, no. Moved a lot of this data. Okay. So this is what she looked like when she originally started with us. And the biggest change was the expression of Delta. She really had a deficiency there, especially on the left side. And in working with her consistently, we've been able to really help regulate that quite a bit. And along with her delta theta regulating, the rigidity would go down and the level of her tremor would go down. Now, what was really interesting was that she was taking L-DOPA, carbidopa, and she decided to back off on her medicines, and as a result, her rigidity really increased with her right foot, all the toes in her right foot literally curling under, like holding a fist essentially, and it was very painful for her. She would attempt to straighten her toes, and it just wouldn't happen. So we decided to run the delta gamma alpha gamma at FZ and PZ, and then run the alpha gamma protocol between C3 and T3 and C4 and T4. And we do 20 minutes of each. And after a single session, she comes in the next day and she said, I was able to straighten my toes and they stayed straight. It literally broke loose the rigidity that was affecting her right foot. And this was just amazing to us. And she took off her shoes. She showed us that we could see the toes were straight, and it remained that way the entire week. Now, again, this is data where if you look at what she actually looked like at the end, this is what she did, what she looked like at the end of the week when we did the cross-coupling frequencies throughout the week with her. And again, this is just Z-score data, but it is compelling when you see the way that delta changes and the response that she had. Cognitively, she was much clearer. She was definitely happier, and her toes remained straight. Okay, so then we have a nice pre-post here, where we can really demonstrate how this protocol all by itself with stim only simply can make a change. If I go through here, all right, let me ask a question real quick to everybody out there. Are there other questions about the data so far? Because right now I've shown you a bunch of data that demonstrates how we can make this change and get it very quickly. Okay, that answered Joe's question. Okay, seeing if anybody else is going to say anything. We have some more pre and post here. If we look at, oh yeah, that's the one I wanted to show you, which was, which one was he? Nope, that's not it. That's not it. There we go. All right, so LORETA post. Okay. And pre phase shift. Now, this is kind of demonstrating this phase shift phenomena a little bit more clearly. And again, the reason I really like this data is that it's not magical. Not every, it didn't automatically just simply become green, On the left is the pre. This is what the kid looks like 20 minutes later on the post. And what you can start to see here is these small pockets of shift. And if you actually look at what areas they're influencing, we're looking at posterior cingulate here. This is area 1 as it's compared to area 10 and 32. And in the alpha range, we have these little places that start to pop up. This is where we had some coils, folks. And it really did influence the system. Now, if we continue to work with this kid in this way, this brain is going to start to open up and begin a process of communication where it can actually regulate itself. I'm going to quickly go through pre-post. Look at this. So again, area 2, 1, 2, and 3, somatosensory cortex. And you can see how it's shut down and how it starts to widen out here. We start to see a lot of normalization in alpha 1, alpha 2. Here's area 3. Again, area 3, we see a shift. There's virtually nothing there. And we're getting these, I'm just going to quickly kind of go through them. And you can see how each Brodmann area has a change. There's a response in each one of these. And again, this isn't magic. It's going to take time to help to work with this kid and help him recuperate essentially from this injury. But it does demonstrate that it's possible for the brain to recover. And my guess is that when this process is started, it's going to take on a life of its own. Essentially, it's going to continue in the same direction. This is frontal lobe. This is where we had coils. And again, this is again frontal lobe. And you can see how we get these changes. And some of them there was hardly anything. But again, if you can see this, then you're going to say, okay, there must have been, if I see this, there must be massive changes in phase lock and phase shift. Of course there were. We see it in every case. All right, so Teresa asks a question, how often do you use this protocol? Is it once a week good enough, and how many times in a row? Now, with the person with Parkinson's, we did it 2 times a day, once in the morning, once in the afternoon, and each time she received 40 minutes of treatment. So she had a total of 80 minutes a day. I am a strong believer in intensive treatment. I believe that neurotherapy, I think that we can get better clinical outcomes with neurotherapy and combinations of this modality along with other modalities if we work with a person more intensively. Think of it in terms of working out. If you only work out once a week, you're only going to get so strong and you're only going to get in so good a shape. But if you're able to work out every day and have a regime that you follow, then your body's going to respond accordingly. And the brain does the same thing. If you're able to give treatment every day, then I think that you can help a person to recover much quicker. Now, if you're dealing with the kinds of disorders that we do here in my clinic, we get some pretty serious cases, people with autism, people with Parkinson's, people with serious depression. Again, if you're only working with them 1 time a week, it becomes extraordinarily difficult to help them to regulate. Can you do this every day with a person? Absolutely. Henry Owen says, could you repeat your protocol with the Parkinson's patient? Yeah, it's the delta, gamma, alpha, gamma protocol. And if you look in NeuroField here, select protocols. Now when you open the database, you're going to see a number of protocols that start with CFC. If you see that, CFC is cross-frequency coupling. That means you're dealing with a stacking protocol where you stack the coils on top of each other. Now, I know I'm going to get this question. What channel is what channel? Now, it's pretty easy, but probably people normally don't notice this. But when you actually start it, let's see, I'll just select the patient. When you actually start the protocol, you'll notice right here, this is the way the coils are color-coded. Channel 1 is black, channel 2 is red, channel 3 is yellow, gold, depending on how you look at it. Channel 4 is blue. So you're going to stack channel 1 and channel 2 on top of each other. So the black and the red coil are on top of each other. And then you're going to stack channel 3 and 4 on each other, and that's the yellow and the blue coil. So I'm going to go back here. So we start with the delta gamma, alpha gamma protocol. Now, let's take a look at this. And this is where I can give myself a little pat on the back after thinking about what I learned from Dirk and Jay that night. And then what this actually means. If you look at this protocol, folks, channel 1 is starting at 1 hertz and channel 2 is starting at 41 hertz. So essentially, you're giving delta and gamma simultaneously. Now, channel 3 and 4 is starting at 9 hertz and 41 hertz respectively. So you're giving alpha and gamma simultaneously. Now, when you stack coils on top of each other, what you effectively do is you create an electromagnetic binaural beat. Because the two frequencies are going to mix together, and the difference between the two frequencies creates the binaural beat. So essentially, when you're giving delta and gamma, you're certainly giving both of those waveforms simultaneously. The brain will copy both of those waveforms. But what you're also giving is a binaural beat of 40 hertz. So 41 minus 1 is 40. So the binaural is going to be 40 hertz for channel 1 and 2. Now, respectively, channel 3 and 4 is going to do this very same thing, but the binaural you give for channel 3 and 4 is going to be 32 hertz. You're still giving alpha and you're still giving gamma. Now, the idea here is to make sure that you give the delta gamma to the frontal lobe. We don't want to give alpha gamma to the frontal lobe. We want to give that alpha gamma to the posterior cingulate. So we're putting the coil on channel 1 or FZ, and then the other coils on channels 3 and 4 we're putting at PZ. And I see a so I need to glue Velcro on top of my coils. Yeah, if you have an older set of coils, then you don't have the newer coils that we have now actually do stack together. If you have an older set of coils, which we do have here, we've simply used rubber bands to put them together, and that seems to work nicely. So the really cool thing about this protocol is that we're definitely giving a gamma binaural beat that is influencing the system, but we're also giving slow wave carriers that allows the gamma to ride on top of it. So that delta is carrying that 41 hertz, but it's also carrying the 40 hertz binaural, which I think is part of the reason why we're seeing these massive changes in phase shift and in phase lock. Now, we would run that one for 20 minutes on a person at FZ and PZ. And then for the Parkinson's person, then what we did is we shifted it. And this one's alpha, gamma. And just like the name implies, you can view these and see exactly what it is. You have 9 and 41 and 9 and 41. So it's doing the exact same thing. And this is where we place the coils over that motor strip at between T3 and C3 and between T4 and C4 and ran it with another 20 minutes. And we did that with eyes open with this particular person. We let her watch a movie because she does come in twice a day. Now, we've also done it with people with eyes closed, and with some people with anxiety and depression, this works very nicely with eyes closed. Now, if you remember from that little PowerPoint, there are rich clubs right under T3 and C3 and T4 and C4. But there's also that rich club that's between T5 and P3 and T6 and P4. And you certainly can drop coils over there and run alpha, gamma. And you can certainly try some different cases or different setups. Wolfgang Kieser says, shouldn't we be careful with epilepsy? Always be careful with epilepsy. But yes, if you're going to use a protocol that gives something below 10 cycles per second, I would be extraordinarily cautious and probably not give the CFC protocol to a person that gives anything below 10 hertz. Now, there is a protocol here where if you look down the list, you're going to see some different ones here. But one of them is SMR gamma. And this one probably could be done with a person with epilepsy, but I don't even know if I'd want to do that. We've had better treatment outcomes with seizure using the 19 to 25 HD protocol. The whole method is to use LORETA time domain capture in NeuroGuide and try to hunt down phase reversals. And you can use the LORETA time domain capture to view these phase reversals in NeuroGuide. so that you can determine where to put the coils, which is incredibly important. Otherwise, the procedure really doesn't work. But if you have a 19 to 25 cycle per second stimulation over a seizure focus, it definitely brings it down. And we have observed that multiple times. Okay. So the first, if you notice, and this isn't it's in particular order because this is the way they were pretty much developed. But the alpha, gamma, delta, gamma, alpha, gamma, theta, gamma, alpha, gamma were my first three that we played around with. I like these. They're very good protocols, but the other ones here also have a very good effect. And you certainly can play around with these at the same settings. Remember, it is very important to use these over a hub. We want to put it over network hubs. So we want to get these hubs to speak to each other. And if we just randomly put the coils in different places without really thinking about where that placement is, I'm not quite sure what kind of effect you're going to get, if any. But I'm pretty sure that these stacked protocols, these CFC protocols, will have an effect over a network hub. The next protocol here is the 783 and 15.66. Let's take a look at that. 7.83 is the Schumann frequency, and 15.66 is the harmonic of a Schumann. So essentially what you're giving here is you're giving roughly SMR and theta together. But you're also creating a binaural beat, an electromagnetic binaural of 7.83. Again, this is a great protocol to run on somebody who has anxiety. I've also, well, I'd say anxiety and depression. People tend to respond nicely to this one. Next one is 7.83 oscillating. Let's take a look at that one. And what this one does is it rings out through the Schumann harmonic. So if we were to actually scope a 7.83 stimulation in NeuroField, you'd see a ringing harmonic that's going to be each one of these numbers, 23.49 or 15.66, then 23.49, then 31.32, then 39.15, and eventually 46.98. It's going to ring out those harmonics whenever you give this protocol. So the idea behind it is to oscillate through frequency bands and get all the way up into the gamma range while creating a consistent binaural electromagnetic beat of 7.83 cycles per second, which is what occurs in each one of these stim cycles. So where are the placements for this? Again, think hubs, okay? Now, if we're going to analyze data and we're going to say, you know, how do I make my treatment decision here? That's a good question. So what we want to do is we'll pull some data here, and let's just look at eyes open pretty, or eyes closed rather. So what I've been doing is I pull open the coherence data, and I'm looking at areas 9 and 10. So here's 9. Let's try to make this bigger. Now what you can see here is on the vertical axis, these are all the Brodmann areas. Okay? On the horizontal axis, these are all the frequencies. Now, when I'm looking at somebody, I'm going to ask myself the question, is the Rich Club online or not? And to me, the Rich Club is that frontal lobe. It's that superior frontal and the superior parietal. It's also the amygdala. It's also the hippocampus and the precuneus. So I want to look at all of these areas and see what's going on in terms of coherence. Now, I can also look at them in terms of phase lock and phase shift, but the coherence in LORETA handles it enough for me as well. So we get a sense of what areas are talking to what areas and what areas are not talking to which areas. And you want to match this data to the person. But remember, in order for the brain to regulate itself, in order for those hubs to begin communication, they have to communicate. If the hubs can communicate, then the rest of the system is able to regulate itself, essentially. So I would start with areas 9 and 10 and look at these and say, okay, are these deregulated and how so, essentially? And I would start thinking about each one of the Brodmann areas. Now, I've been saying this for a while. The time has come for you to know your LORETA Brodmann areas. It's time to start to learn them and place them in memory, because you're going to ask the question, where do I want to put those coils? Well, you need to know what regions, what hubs are offline and what hubs are online. And so what I mean by offline is, if you look at this, for instance, area 10 and area 45 and 46 are offline. And what you can do is, there's a number of different websites where you can look at Brodmann areas, and you can look at what they actually do and what their function is. And that's what I would suggest doing, is pop open your web browser and start looking for your little cheat sheet that's going to tell you what site does what. And here you can see area 10 is having a hard time talking to the dorsolateral prefrontal lobe. And again, then you're going to ask myself, or I would ask myself, is this a problem that the person has? Do they have executive function problems? Do they have mood problems? If so, then I want to address this. So then I would pop over to area 23 and 24 for the anterior cingulate and take a look at that. And again, you can see where there's all this hypocoherence. In the past, you certainly can combine this with NeuroGuide 19 channel Z-score, for surface and or LORETA, and you could run this protocol for a period of 20 minutes, and then you could have a person run another 20 minutes of EEG NeuroGuide, or whatever flavor of EEG that works for you. But essentially, what this is going to do, based on the data that we have so far, is it's going to create a shift in the pendulum from one degree to a strong shift to another degree. And when that occurs, you have a window of opportunity to train as the system is attempting to regulate itself. And that's where you could run different kinds of programs to achieve that. So again, I would look at areas 9, 10, 24, and I would pop over to 29. This is posterior cingulate, 30, and 31. Now, there's a lot of ways to look at this, but that's a start. That's where I would begin. All right. Let's see here. Another question. How about reactive attachment disorder? Good question. I don't know. That's the official answer. We'll have to see what that one does over time. My guess is that it should have an impact. A good one, too. The next one is alpha-gamma amplitude oscillation. Pretty simple, huh? It's simply alpha and gamma put together in one protocol, and it's going to create a 32 hertz binaural. The trick with this one is that this is a longer one. It actually gives 20 seconds for each stim cycle, so it's a longer pulse. It tends to have a good effect, though. So again, these are hot off the press, folks. I have more experience with the delta gamma, alpha gamma than most of these other ones, although we have been using the D-tag on people. 136 and 277. For those meditators in the crowd, this is your protocol, or at least it's one of many. 136.1 is the mid-range Om. And if you think of sound healing in meditation circles, the Om is much more than I can possibly describe. But this is the mid-range ohm at 136.1. The low-range ohm is 68.05, and the high-range ohm is 277.2. And the way we have these protocols set up, it creates a binaural of the mid-range ohm and then switches to a binaural for the low-range ohm. And it'll take you back and forth between those two. It's at 10,000 milliseconds. You do this with eyes closed, FZ and PZ. Now, when you're placing those coils on the head, you want to make sure that that posterior coil goes right over PZ. But you certainly can do protocols where, like alpha gamma, where you put the coils at P3 and P4 and touch them together at PZ. Alternatively, you can create a delta gamma, and then do F3, F4 touching together at FZ. And then you could go more towards the prefrontal lobes so that you really do hit that hub. All right. D-tag. This was named Consciousness Rising by Tiff, but I had to change it because I did modify it a bit. What this does is it gives, there's 5 different stem cycles there. You can see it starts with 2 and 4, 5 and 10, 7, 8, 3, 15, 6, 6, 9 and 45, and 11, 44. This protocol we have found is one that really helps people, if they have brain fog, it really helps to wake them up. If they're depressed, it helps to lift them out of depression. It is creating a delta binaural. It's creating a low theta delta binaural. It creates a higher theta binaural. Then it creates 2 gamma binaurals, and for each time that it runs through the protocol. We like to pair up 2x3000s, and when you do that, you can run 4 sets of stacks essentially, and so then you can cover 4 network hubs. So you can put it at FZ, between FZ and FPZ. You can put another coil at PZ. You could put another stack at T5 to P3 and another stack at T6 to P4. Or alternatively, you could move those stacks forward and go between T3 and C3 and T4 and C4. This protocol is very good for waking people up. All right. Here we have the ultra low protocol. This one goes below delta, starts at 0.31 and goes to 0.39 while giving gamma. Again, the research has shown that gamma will ride on top of a slow frequency carrier. The bigger the slow frequency carrier, the more of an impact that it's going to have. And the good thing about this one, this is a pretty gentle protocol, but it is going to have an impact that probably is going to be a little bit stronger than the delta gamma, alpha gamma. That would be my guess. It starts at 0.31, makes it all the way up to 1 hertz, and again, it's giving gamma all the way up to 46.9 hertz. And again, you're creating a different binaural each time as it ascends. But again, this can be used in the very same way that the delta gamma, alpha gamma protocol be used. Again, I'm very, very big on that FZ, PZ, and then basically T5 and T6 configuration because that's firing up all of the major hub systems in the brain. Now, one of the things you can do is you can follow this protocol with a linear protocol. What I mean by that is you could select a protocol, go down to, if you keep on scrolling down, then you can see all the standard protocols. At that point, because you've thrown the brain into a shift state, it's locking differently, it's shifting differently, you can introduce a linear protocol at this point. Where you give 1 to 4 or 12 to 15 or something, whatever flavor you want to give a person, and you can introduce that to the system and get it to generate it. And so basically you would be unstacking the coils when you did this, and you'd be using individual coils at different places on the head. And so that's one way of doing it. You can integrate a stim only after giving a CFC protocol. You can do a CFC protocol and do a, like I said, 19-channel Z-score treatment immediately after. Again, you're going to open a window of opportunity. My recommendation, if you're going to do Z-score, train networks, because you've just fired off a network, and my guess is the default mode network, the salience network are both going to become extraordinarily important to look at when you're training somebody. But you might want to start with the default mode network in LORETA to see where it's at. And what I mean is that I think that the brain is going to, it's going to respond to the CFC protocol. And when that window of opportunity opens, that data is going to look a lot different than your initial cue data. We know that only 20 minutes later, the entire expression of the cue changes. So you can certainly choose any one of the linear protocols and give it, or you can do a linear protocol. One of the other things that we're doing here is, now if you notice here it says enable multi-stim broadcast. When you click on this, this enables your second X3000 that's connected to the system to activate. So in that way you can run two of them. And this is what we call the octopus. And so if I enable this and close it, and I have stack coils going on, and I have 4 sets of stack coils, you can actually run stack coils using the dehabituator. Now this is pretty darn cool. If you think about the way this is going to work, now we're creating random binaurals with the stack protocol. So channels 1 and 2 here are going to 3.8 and 1.72. It's going to create whatever the difference is between those two frequencies. That's the binaural that you're going to give, along with giving the 2 frequencies from each channel. So these are going to create a whole nother way of dehabituating the brain. If the hub is hyperlocked and you can't evoke change, then I would look into dehabbing the system using stack coils. It's another way of being able to influence some pretty big change pretty quickly. All right. Next one, spectrum 1 to 40. All right, and so what you see here is starts at 1 hertz and 44. It goes all the way from 1 hertz to 1.9. Then it's going to switch. So you're starting at delta, then it switches to theta from 5 to 6. Then it's going to switch to alpha from 9 to 10, and the whole time it's giving the same gamma frequency. So it goes alpha 9 to 10, then it's going to go to low beta from 14 to 15, and then or SMR rather, and then you're going to get low beta from 19 to 20. And again, giving gamma each time. And so in this one, the idea, I keep on repeating this so that you'll get it, that the idea is that you're giving 2 different frequencies that's going to create a binaural as well. So it's 3 different things that are happening at one time. In this particular protocol, it's going to carry you up from delta all the way up to low beta. And again, that's going to shake up the system. It's going to get it to move. And the whole idea behind these CFC protocols is to get the network hubs to talk to each other. SMR gamma. All right. starting from 12 to 13, 13 to 14, and eventually 14 to 15. Oh, it's going to go all the way up to 16. So we even touch low beta here. We start in SMR and we end in low beta. And again, the frequencies are going to climb. If you notice here, we're at 42 to 43, then 43 to 44, 44 to 45, and eventually 45 to 46. So you're creating a different binaural in each one of the stem cycles. All right. I'll field a couple of questions here because I see some coming across. So Adam says, would you suggest we not do this with someone with low eagle strength, as you mentioned with the tag? This is going to influence a person. Would I not do it? It really depends on what the person has around them. And what I mean by that is, if I was to use this protocol on a kid, which we've done, the child may experience all sorts of emotional responses. And that's okay in my book. What's really important is, does the child have people around him or her to prevent any abreactions that or any outbursts that would be inappropriate? Does the child have an adult, a responsible adult around him or her that can contain the child, that can be with the kid, can wrap invisible in strength around the kid so that the kid can tolerate these changes and go through it? It's not necessarily a bad thing. It's a bad thing if the person is just left to their own resources and doesn't have any resources to manage the emotional experience that they may have. So it's not that I wouldn't do this with a kid. I would be assessing what is capable or what's around the kid. What does the kid have to help balance that experience? Okay. Let me open the floor to questions here. Let's see. Oh, I see. There are quite a few, actually. Kind of go through it. There's another question. Can we substitute this protocol for alpha, theta, gamma? Sure. Certainly can. You can run a CFC protocol, then you could run an alpha, theta, gamma protocol. I don't see why not. What I would do, though, is that I would unstack the coils so that you're getting the individual frequencies coming through and not some strange binaural. In each one of these, I'm really thinking about what that electromagnetic binaural is going to be and how it's going to influence the system. I'm also thinking about what placements I have here and what network hubs we're going to influence. Once I actually finish giving a CFC protocol, we might really take the coils off and put them in different locations based on the cue so that we can help the brain to respond and regulate itself. So if a person's low on delta, we might do CFC for a bit and then unstack and put the coils over that delta deficient area and then give delta directly. Ruth Kreider says, if used on younger children, do you think the high gamma may be too high? I'm thinking about harmonics of their lower alpha peaks. If it depends on how young of a child we're talking about. I'd say we'd want to look at how this could, 6 or 7, I'd say probably would be fine. I would be concerned about giving too much gamma to a baby, anything below 3 years of age. But 6 or 7, I'd say it's probably okay. When you're looking at kids usually have a lot of alpha. As babies, they're in an alpha state quite a bit. And so we don't want to get in the way of that. But my guess is that, the brain uses gamma the way it needs to in order to regulate itself. But I think you're going to be fine with a 6 or 7-year-old kid. Really, what I would look at is the duration of the treatment. When you're actually giving delta gamma, alpha gamma to a kid, I would start at maybe 10 minutes or maybe 15 minutes at FZ and PZ, and then move those coils for another 10 or 15 minutes for a total of 20 to 30 minutes at the most to begin with. And if you really want to be conservative, you could start at 5 minutes and 5 minutes or 10 minutes and 10 minutes. You really want to assess the kid for sensitivity issues. And that's going to help you to make a good decision. In some kids, you'll find that the posterior cingulate is low-powered, and they may have, developmental issues and a deficiency in alpha. And when that system comes online, it can be quite startling. It can be quite uncomfortable. And it's important to be able to acknowledge that, because the kid all of a sudden may be experiencing a huge influx of sensory information, which can be overwhelming. That parietal somatosensory area can come online, and all of a sudden lights are brighter, sounds are louder. So you really want to make sure that you're taking that in consideration when you start with a kid, and see whether or not they already have that kind of problem. If they do, you're going to say, okay, I don't want to go too hard on them at the beginning, because this is an overactive system as it is. So we want to start slow and then build them up. But every kid's a little different, But I'd assess them for light and sound sensitivity, food sensitivities, allergies, stuff like that. That'll give you a sense of their overall sensitivity level. And then, based on your evaluation of the kid, you want to trust your clinical instinct and match that to the numbers that you see. If you see a lot of high beta or inflammation, then that kid really may be easy to reach with these protocols. It won't take as much. So you really want to look at that. If they blink their eyes after 10 minutes and there's absolutely no response, then that also gives you an answer. All right. Now that the remainder of the protocols are here, delta delta, theta theta, alpha alpha, SMR, low beta, high beta, and gamma. Basically, these are all combinations that keep you within that frequency range. And I just created these not too long ago, so I have very limited experience with them. But my guess is that if you want to influence a specific frequency band, this is the way to do it. And so you can choose which one is either high or low, and if a person doesn't have enough theta, you can choose the theta protocol and try it. See something else that just came across here. Pete Deshane says, my son, 7-year-old, has responded very well to these protocols. They're calming for him. LORETA or single channel afterwards is doing nicely, doing 6 minutes per site. Okay. Yeah, Peter was at the... Hey, Peter, do you have your mic on? I'm curious. Because that data is pretty... Here we go. Peter, your mic is live.
All right. Can you hear me all right?
Yeah, I can. So at the Virginia Beach training, we talked about your son. Is it okay to talk about it now?
Absolutely.
Okay, cool. I'm just curious to hear what his progress is, because his kind of problem is significant, and it's not easy to make movement with him. So I'm wondering what you've seen so far, and if you'd share that.
There's been a combination of things. Certainly, a bit more speech, but what I would say is a lot more empathy.
More empathy.
things like at the end of the day, I was sitting down on the couch looking a little tired. He came up, looked at me, and then he went into the other room, grabbed his favorite helium balloon and brought it to me and gave it to me. You can see he was like, "Here, Dad, it looks like you need a balloon tonight." So it's a really nice connection that way, a lot more understanding. And the thing, we've been doing a lot of work with this default mode network prior to this. So it was not bad, but the one that we switched to with the LORETA training just recently was Salience Network. And the Salience Network is really lit up as chattiness.
Okay. Okay.
And, so I think one of the things was very dramatic. I don't have the phase shift and phase lock module, but I was looking at his coherence shifts, and the coherence right afterwards, huge differences. And I think you're right. The areas that were hypercoherent swung the other way, and the areas that weren't talking started to really lock into each other. And I've come to appreciate when I'm looking at his data, there's there's the right after the treatment, and then there's 2 days later, and each one is very different. And looking at the one right after, at first I was like, holy cow, I think we've just articulated his default mode network, but now that I'm seeing the results, what I really think is we're momentarily putting it on hold and letting it reassemble better.
Mm-hmm. Mm-hmm. It would make sense. It seems like we catch a brain in transition when we look at that data right after the stim. So 2 days later, you're saying when you look at it, it's looking a lot better.
Mm-hmm. Yeah, it's really nice, and the LORETA training is a really nice add-in. Like, it seems to be going that much smoother now that we've had the CFCs to get things moving. It seems like a very potent pattern interrupt for his central nervous system.
Okay. Well, thank you very much for sharing that. I appreciate it. Definitely. There's Patricia. Pat? Can you hear me?
I'm sorry, I had to unmute myself. Yeah, I was really excited about that first CFC session with my long-term drug-addicted client who said he was really, and he acted really surprised about it, that his panic topped out at a 6, and it just wouldn't go higher. So I'm really looking forward to seeing him. I train him 2 times a week. So and last week was the first time I used the CFC with him. So I'm really looking forward to his input this week.
Well, thank you for that. Okay, good. This is good information to know. Yeah, I'm excited too. And let's collect good data as we go along to see how this person, how they look and how they change.
Well, unfortunately, I wasn't doing it with the cap on. Basically, I was just doing the sessions. So I'm going with the behavioral correlates right now.
Yeah, so you have some pre-post those, right? Cues.
I have a pre, and I just did a post just before he came back into treatment. So I have 2 cues on him.
Okay, good. All right.
Okay.
Mm-hmm.
Okay.
Thank you. Let's see, Pat, Nick, are we breaking up beta here or what? Where are you, Mike? Mike, put your mic on here.
Hello.
There you are. Oh boy, can you shut off that external speaker? Got a lot of echo going. That ain't gonna work.
Hello. Sounds like Pink Floyd.
It does. You're playing a guitar back there. What do you mean by the breaking up beta?
Well, just the thinking that with Valium, your EEG is being disrupted by excessive Valium, excessive beta.
Right. Well, it certainly could be. I mean, the benzo is going to create an increase in high beta. Dude, I got to mute you. Sorry. Wow, that was intense. Okay. But yeah, the benzodiazepines can increase high beta, so it certainly could have an effect in that way. But I think it's more than that. I think that we're getting network communication to occur in a way that we haven't before. Merlin. Okay, Merlin, I'm going to put you on. Hello, darling. Are you there?
Oh, I guess I'm here, huh?
Uh-huh. Now, yeah.
Oh, yes, I am.
Hi.
This is one of the cutest little kids. I saw her on Saturday, and to say that she sat in the chair for 3 seconds is saying a lot. I mean, she was all over the place. She called me Grandma. She hugged me. She was like, I mean, a delight. But doing even 7 minutes, I was able to get 1 minute out. You know, I squeezed it out. But when I looked at Phil Jones's phase shift, oh my God, totally negative. I mean, totally negative. Like she has her shifts are so tiny that, and that's obviously what contributes to a lot of her hyperactivity.
Sure.
Of course she's been diagnosed, you know, as ADHD, and she's not. She's absolutely not.
Interesting. Yeah, that's and getting those LORETA phase shifts to occur is some of the most difficult stuff to do, really.
Right.
And that's why I showed you that data earlier, where I just kind of quickly went through that phase shift. You can see how it begins. You know, in that 20 minutes, there was alpha regulation that was popping up left and right. So, you know, you certainly could try, you know, take a look at those hubs. You know, that's really the big thing to do. When we look at those hubs, we can get a sense of where the system is regulated and where it's not regulated. Let's see here. Where's my USB? Oh, I have that picture. That's not it. The Rich Club. No, that's just the article. I'm going to be throwing this article into the NeuroField download right here. Rich Club Organization of the Human Connectome. I really like this stuff. It's going over a lot of information that we need to start thinking about, because we're going to definitely be influencing it with these cross-frequency coupling protocols. But there's our Rich Club right there. So what you really want to do is start looking at that superior parietal and that superior frontal, because you can see that the way it's connected here. Those are the areas that are going to basically act as a connection for every other Rich Club in the brain. It's the one with the highest amount of connections. And so with this little kid, what I would be looking at, again, areas 9 and 10 for frontal lobe, anterior cingulate, posterior cingulate. So you want to look at 29, 30, 31. You also want to look at 24. All those are going to help you to make a determination if you think this kid would benefit from a CFC protocol.
Okay.
And what I found, and this is, you know, I get excited about stuff like this. So for me, everybody that comes in, I start looking at it, and almost everybody has an issue with the Rich Club. In one way or another, there's a piece of it that's not online. And if you influence it, then the rest of the system starts to respond. And then you could use other methods that you normally use. So you can do just a very short smattering of a CFC protocol and see how it hits the ground, whether it should bring down that high beta. We've seen dramatic decreases in high beta with just a single session in people.
The high beta is over the central and then the parietal and the occipital. And I mean, that's beta and high beta. The interesting part is it doesn't seem to be in the frontal, which I mean, now I've looked at it from every angle I can think of.
Okay.
But it doesn't seem to be, which is, it should. And if it's going to be around the central and the parietal and the occipital, I can't understand why it's not there in the frontal.
Yeah, it's hard to say.
Yeah.
Hard to say, but it's definitely, one of the things that Dirk de Ritter really did, he really did stress this point when he talked about the posterior cingulate being probably the most important hub. And I remember him saying that in terms of just LORETA treatment, he felt like that was the hub you really wanted to focus on. So this precuneus, parietal area in the back of the head, and for your kid here, that system, I would look at the connectivity for the precuneus and for all those parietal regions.
Her precuneus comes up as really 6 to 7 standard deviations from the mean. Yeah.
Really? Okay. Well,
yeah.
That gives you an answer right there.
Yeah.
Well, and so, I'm putting up this, I know this is Wikipedia, but I love this this particular page. I found it to be pretty good in terms of just giving you some information. There's fMRI Consulting /Broadman. That's also a good site for getting information. But this will also give you information here when you want to know more about each one of the regions. Okay. But so in terms of your kid, that's what I would do, Merlin.
Yeah. Okay. It was just I've actually never seen where the shift is so low. It startled me.
Well, that doesn't surprise me. I've seen that many times. Where the shift is the LORETA phase shift dynamics are incredibly low, and it makes me wonder whether that data is correct. Number one,
thank you,
because I'm not everybody is 3 standard deviations below the norm for phase shift. But with that said, when you see a change where it's a 3 standard deviation change, then you wonder, indeed, is that what is that? What just happened? And so what we end up seeing is these really long phase locks and then longer phase shifts. But the system will respond.
Yeah. Yeah.
All right, sweetie. Here we go. Any other questions? Let's see. Oh, yeah, says more. Are you using Brain Surfer to show the client his deregulated hubs? Not right now, but I certainly will. I think that's probably a good one. That one was from Wolfie. Mike Gismondi says, at Cancun, Dirk really stressed the superiority of connectivity over amplitude treatment across the boards. He did. He certainly stressed connectivity. And now I think I understand why. Because if those hubs can't hear each other, then your amplitudes are going to be all over the place. But as soon as the hubs can hear each other, you start to get a regulation in the amplitudes. And so if you think what comes first, the chicken or the egg, I think that connectivity leads to regulation of amplitude, probably more times than not. Let's see. And Lisa puts up a link for the Rich Club. Yeah, cool. Sessions we've run sessions at 20 minutes of the delta gamma alpha gamma, then we move the coils, and then we run alpha gamma for another 20 minutes. Or what we've run is sessions where we've simply given maybe alpha gamma. We have a depressed lady right now that we're working with, and she gets alpha gamma, and we're doing it more so to the back of her head than the front. And she's responded incredibly well to this. We use the octopus on her, and we give her, I think it's 20 to 30 minutes altogether, and she responds nicely. If you don't know, then, what I suggest is that start slow. Give a person maybe 15 minutes and see how they respond, and then you can start to titrate it up. Would I follow with 19-channel LORETA? Of course. You certainly can do that. just monitor I would say monitor the fatigue level. Now, I don't know if Tiff has got her microphone on, but she was the one who did the 2 and 4 hertz protocol. I'm going to see if I can get her to talk about it. Where is she? Aha. Tiff, your mic is open.
Can you hear me now?
Yep.
Sorry. Got
No,
better?
you got, can you shut off the external speakers?
Yeah, it's my phone. I just turned it
Or it's really, oh, yeah, there you go,
off. Now I
perfect.
can't hear anybody else. Okay, well, I'll call back in after.
We can hear you though. Okay, so
after I stop talking, but I'm assuming everybody can still hear me because I can see my microphone rolling. So, yeah, 2 and 4 hertz I've found for whatever reason works really well for anxiety, particularly high beta in the back of the head. I've had more than one client remark immediately that they feel a sense of peace, of relief, greater sense of well-being, what have you. And so it actually might be detrimental to your practice because people generally get what they need very quickly. So that's good. And that's all I have to say about 2 and 4. I'm going to call back in and mute, Nick, mute me on this phone.
okay, you got
On
it.
your
All right,
speaker.
thank you. All right, so the one she's referring to is this delta CFC protocol. It's 2 and 4 hertz. Remember, you're giving 2 different kinds of delta, and you're also giving a 2 hertz binaural. So that's really some of the magic here, but also placements are key. You know, she's talking about putting it over the back of the head. Remember, you have 4 major sources of the rich club back there. You have the precuneus, and then you have the superior parietal, and you have it on each side of the head. So if you place your coils accordingly and actually get them in the right spot, you can really influence the system quite quickly. Okay. Let's bring it down here. Rick says, almost everyone in our clinic is 2 or 3 standard deviations below the norm on phase shift. I'm assuming you mean a LORETA phase shift on all Brodmann areas. Is there a logical reason for this? Good question. I don't know. I think there's maybe a little bit more tweaking that has to occur with the phase shift data. I don't have an answer, but it's certainly something that I'm going to address very soon here. When I see Bob this weekend, I'll have a discussion with him. So Adam says, I assume that it's better to focus on one network at a time, 2 hubs. You can do more than that if you have more than, you can put 2 X3000s together and then get, you know, you can basically go after 4 regions. But 2 hubs at a time is what we've been doing with people. The 2 and the 4 hubs seem to work nicely. Suggestions for sleep problems. Well, again, I would be looking, examine the coherences, Dick, on those posterior hubs and see what the distal relationships are to the front of the head, and look at that connectivity. That's probably where there's going to be an influence. Okay. So Grant says he has a lady with posterior high beta. She has small vessel disease and goes to sleep in most sessions. What CFC would you use? Again, we want to look at that data and make a determination. But what I would say is you might want to try the delta gamma, alpha gamma, and then alpha alpha, and see how that one works with her. But delta gamma, alpha gamma from the frontal to the posterior, and then alpha gamma from the T5, P3, T6, P4 regions. Should have a good effect. Any thoughts on about overall low amplitude? Boy, that's a tricky one. Really depends on the person and what clinical presentation that they present with. Mike says, Nick, are you sticking to square waves when you do this work? You want the harmonics, right? Yeah, right now we're doing square waves, but the system has the ability now, if you have the new X3000, to do sine and triangle. What we found was that right now square waves seem to affect the system differently than sine. I'm going to have to do more work in that area to figure it out. But right now you square waves, which is what everybody has. So everybody's good to go here. Regardless of what, if you have an X1000, a 2000, or a 3000, all three of those systems work off of square waves. So you're all good to go. Pat says, have a man with low alpha and presents with severe brain fog. Any suggestions? I would try the DTAG protocol on that person. The DTAG protocol seems to clear up thinking nicely, although I think the other ones do too. But that protocol is it used to be called consciousness rising, but it definitely influences your I guess your clarity, if you want to say it that way. All right. Let's see if there's anything else that I didn't cover here. I pretty much hit everything that I wanted to hit. So, folks, now let's think about this for a second. It's important to start thinking about what paired frequency has an impact on what frequency band. Now, this is all brand new stuff, so we can start playing around with it in different ways. But, you know, my focus has been on that delta gamma, alpha gamma, based on the research of having a slow frequency carrier take gamma and lift it up essentially to carry gamma. So that's where this all began. But since then, we've played around with a whole bunch of different combinations, as you can see here, and there's room for a lot more. I think if we actually create a bunch of different kinds of binaurals, we'll find that some of them have an impact on some frequency bands, whereas not on others. So one of the things I want to, encourage you to think about is what binaural does what CFC protocol influences what frequency band. If you make an observation and you have the data, then I definitely want to see it. And that's something that we can continue to talk about on the listserv. I'm also, I'm very interested in seeing that posted and discussed. So that's one thing I would encourage you to think about is, what binaural does what. Okay. Yeah, the theta gamma is a major pairing, definitely. That's a good one. The delta gamma as well. I think that's dictionary says that. Leo says, when doing some pairs of frequencies, theta, what you're actually doing is synchronize the areas that you're working with on it, isn't it? Yeah, it's going to. I believe that's what's going to happen. When you're actually giving it this two frequencies that are within the same frequency band and creates the same binaural, then I believe that you're actually going to have an entrainment effect on that area. And it's probably going to be pretty powerful. Let's see. Yeah, I'm reading what's here. All right, well, Wolfgang says, any chance that Brad will make some coils which can be used in an fMRI? I'm wondering if our coils could be used now in it. We'd actually, obviously, we'd have to test that to make sure that it would be safe. I'm pretty sure that it would be. It's not the way I'd want to do it is, well, I'd have to think that one through, Wolfie. It's a good question. Maybe someday we can cross that bridge. There's a lot that goes into, the circuitry and what happens when the system's exposed to real high-level electromagnetic pulses. However, yeah, Daniel could use them. I agree. I think it's possible. I have to look at the electrical safety testing that the X3000 went through. I'm pretty sure they hit it with a pretty high level of different kinds of sources, including EMF. So we'll see what it actually what it can take. Kathleen Friend says, do you think there would be any benefit to do a CFC protocol on the body? I have a patient very afraid of the cat, but will allow me to put coils on her body. Wow. I don't see why not. I don't see why not. I don't know what it's going to do. Honestly, the official answer, Kathleen, is I don't know. You could try, yeah. Wolfie says Nogier frequencies for it. You could certainly try to create some CFC protocols that create a binaural of the Nogier frequencies. That would be next on the list. I'm sure Annie's listening right now. Annie, why don't you jump on that? We can get those made up. HRV training, then trained alpha. Well, sure. Lots of good ideas, folks. A lot of ways to skin a cat. All right. Well, with that said, we've come to the end of this little soiree. I hope this was helpful for you, and I hope you enjoy using the CFC protocols. Please post your data. Please engage in the discussion on the listserv so that we may facilitate new ideas and expand the understanding of what these things are capable of. I'm pretty sure that we're just touching the tip of the iceberg here. There's a heck of a lot more we can be doing with it. So, with that said, folks, I hope you have a great day, and thank you for coming. Take care.